Sir, we are live now.
Okay, I'll have to share my slides.
Yes.
Good afternoon, everybody, and thanks IGCP for having this seminar or the webinar on the myocarditis. As we all know, myocarditis is usually a neglected disease, and most of the times it is missed because we don't pay attention to diagnosis. But in recent times, especially in the COVID era, there is a number of cases where direct or indirect involvement of the myocardium because of the COVID virus, and that's why the interest in the myocarditis has again taken the forefront. So, as far as the clinical diagnosis, or in the broad sense, myocarditis is concerned, it refers to the inflammation of the myocardium, which can be secondary to the any cause, either because of the injury or because of the infection or some chemicals which have been exposed, or maybe some of the forms of genetic cardiomyopathy. But if you look at the more specific terms, classically myocarditis refers to the inflammation of the heart muscle, especially the myocardium, as a result of exposure to either external antigens, which may include viruses, bacteria, parasites, or toxins or drugs, or maybe because of the internal triggers, which leads to because of the autoimmune activation of the self antigens. So any of these factors can lead to development of inflammation and finally the myocarditis. Viral infection remains most commonly identified cause of the myocarditis in most of the clinical presentation, and that is these are the most common cause of myocarditis. However, the toxins or drugs may be common, especially in some special conditions where the person is exposed to the chemical in the chemical factory or some environmental factors. They can be important factors for the agent of myocarditis is concerned. Pathogenesis of myocarditis is a classical paradigm of the cardiac injury, which is followed by a immunological response secondary to the host response to the parasite or foreign body. And the relative incidence of viral causes is continually evolving as the new diagnostic tools are based on molecular epidemiology are available. More and more number of patients with myocarditis, especially viral myocarditis, are being diagnosed because we have better diagnostic facility. But still, there's many things which are lacking, and the field is evolving. As far as the viruses are concerned, more than 20 viruses have been associated with myocarditis, and most frequent of them are parvovirus, that is B19V, or human herpes 6 virus. Other viruses like Coxsackie virus or enterococcal virus are also common causes of viral myocarditis. The most immune response, most of the patients sometimes may be overwhelming or inappropriate. The inflammation, it may destroy most of the myocardium, and it may lead to acute development of dilated cardiomyopathy in DCM-like picture, which can give rise to the heart failure and even death in some of the patient if there is no recovery in time. But most of the time, it is fortunate that most of the patients who develop myocarditis, the clinical myocarditis is a self-limiting illness, and within 4 to 6 weeks, the myocardium, the body takes care of itself, and viruses are cleared from the body, and the heart functions are down modulated, and the heart recovery takes place. So there is no residual damage, and usually patient improves, and their normal LV function is restored. Sometimes viral genomes may persist in the heart with or without inflammation, which has been proved by endomyocardial biopsy even after a long time of the clinical evidence or clinical incidence of the myocarditis. So there may be dormant form of viral in myocardial tissues if they do biopsy because of some other reasons. But they may not be clinically relevant because they may not be associated with the future myocarditis. As far as the epidemiology of the myocarditis is concerned, in 2019, Global Burden of Disease documents, it has estimated that almost more than 7 lakh people have suffered from the myocarditis, which gives the prevalence rate of about 9.2 per 1 lakh population, which is slightly increased compared to the earlier data, which was presented in 1990, where the prevalence was 8.04 per 1 lakh population. And if we look at the disability adjusted life years because of the myocarditis, it is around almost 10 lakhs in 2019. So which is again significant number because most of the population is usually the young working population. And there are estimated around 32,000 deaths, which gives rise to the death rate of 0.42 per 1 lakh population, which is low, but is still significantly higher. And death rate for myocarditis is higher in the first year of the lifespan. So if the myocarditis happens to be in the younger age, especially below the age of 1 year or up to 14 years, the chances of death because the complications are more compared to the older population. And after the age of 50 years, 15 years, the death and the disability is significantly less compared to the younger populations. So if you look at the geographical distribution in all over the world, the Southeast Asia and the Central Europe and Central Asia have the higher incidence of death, that is around 0.79 to 0.76 per 1 lakh population, compared to the high income group and the Western population, where the death rate is around zero point 0.2 to 0.29. This may be because of the different geographical distribution, maybe because of the underlying susceptibility of the population or genetic variation, or the availability of the treatment which is available, especially in the Western population. The high level of treatment, is, especially advanced treatment like ECMO or LVADs, are available, while in other countries it is not available. So that may lead to the increased number of the deaths. And if you look at the sudden death, myocarditis can lead to sudden death approximately 2% of the infants, 5% of children, 5 to 15%, 14% of young. So most of the sometimes the patient may not have any clinical evidence or clinical syndrome of myocarditis, but they have subtle myocarditis, and patient may be presenting as a sudden death. And if you do the histopathological examination or biopsy, we may find that there is evidence of myocarditis, which may be one of the leading cause of unexplained sudden death in young patients. As far as the diagnostic criteria is concerned, the histopathological diagnosis based on the myocardial biopsy is the gold standard, and the original Dallas criteria is still used as far as the endomyocardial biopsy definition or classification of the myocarditis is concerned. And this includes the idiopathic myocarditis, where the inflammation or inflate are present, which may be associated with necrosis or degeneration of the adjacent myocardium without evidence of ischemic damage associated with the coronary disease. So the absence of coronary disease and the presence of inflammation, which makes the diagnosis of myocarditis as the gold standard. So depending on whether you do first biopsy or the subsequent biopsy, if their myocarditis with or without fibrosis, borderline myocarditis when repeat biopsy is required, and if there is no evidence of inflammation or infiltrates or fibrosis, then there is no evidence of myocarditis. So endomyocardial biopsy is again the gold standard for the diagnosis of myocarditis as far as the diagnosis is concerned. On subsequent biopsies, if we have ongoing inflammation, so the diagnosis of persistent myocarditis, that means there is active inflammation is going on after a repeat biopsy of 4 weeks. If there is healing, then it's labeled as resolving myocarditis. And if the lesion is completely resolved, there is no evidence of inflammation, and without any evidence of fibrosis, this is labeled as the resolved myocarditis. Depending on the extent of the inflammation on the histopathologic examination, it can be divided into two categories depending on the fibrosis or inflammation. So either it may be focal, confluent, or diffuse if the inflammation is diffuse. Similarly, fibrosis may be endocardial or interstitial. Depending on the extent, it may be mild, moderate, or severe, and fibrosis can be mild, moderate, severe on the histopathological examination. And depending on the type of the inflammatory inflates, it may be either lymphocytic, eosinophilic, giant cell, granulomatous, or neutrophilic, or it may be mixed myocarditis, and it may be perivascular replacement of fibrosis. The importance of biopsy is important because this may guide the definitive treatment, especially in some of the patients like giant cell myocarditis or sarcoidosis, where we have some specific treatment available. Otherwise, most of the patients with myocarditis, usually the treatment is symptomatic and it is supportive. There are some new developments, especially in the form of specific immunohistochemical stains, which can detect cellular antigens such as CD868 or macrophage human leukocyte antigen, or its complementars like C4D in most of the patients. So these are some new developments as far as the histopathological diagnosis of myocarditis and detection of inflammation and specific antigen or specific viral myocarditis is concerned. Newer immunohistochemical stains have greater predictive value for the cardiovascular diagnosis of myocarditis compared to Dallas criteria. And the presence of viral genome in the heart tissue may indicate there is active myocarditis. And if you have subsequent biopsy and the viral genome is persistent, this leads to the development of LV dysfunction and poor prognosis compared to those patients who have no evidence of persistent viremia or persistent viral genome in the endomyocardial biopsy tissues. So new diagnostic criteria that rely on the higher B9V copy numbers is one of the important the markers as far as the rate of complication in B19 virus is concerned. So most of the new diagnostic criteria are basically just to assess the severity of the disease and to assess the prognosis of the patient with myocarditis. So coming to the specific etiological details, most of the causes of myocarditis, as I already discussed, it's because of the most of the times viral infection, but it may be chemicals, drugs, or toxins, or some immunological abnormalities which can give rise to the myocarditis. And as we have discussed, advanced virology or immunological or molecular technology leads to the better diagnostic yield compared to the clinical examination or clinical sign and symptoms to make the diagnosis of myocarditis. So this slide shows the most of the comprehensive analysis. What are the agents which can lead to myocarditis? Like if you look at virus myocarditis, adenoviruses, cachexia, rubella, SARS-CoV, and other varicella zosters. Bacterial infections, most of the infections we usually do not consider as a cause of myocarditis can be the cause of myocarditis, like Salmonella, which is infective agents for typhoid, syphilis, tuberculosis. Especially in Indian contexts, it is important always we should try to look for the tuberculosis if there is long-term evidence of myocarditis. Cholera, and similarly diphtheria is in the young children that can also lead to the myocarditis. Cardiotoxins like anthracycline is the most common drugs, which are used as the anti-cancer drugs, which is the most common cause, especially in females, where in breast cancers, they are the most common cause of anthracycline toxicity and myocarditis. Other drugs like copper, cocaine, ethanol, malaria, mercury, protozoa can also lead to myocarditis. Hypersensitivity reaction is one of the important cause of myocarditis, especially in young children, is the Kawasaki disease. And sarcoidosis is also one of the important factors, especially in South India, where more number of cases of myocarditis are being diagnosed because of the better availability of the PET scan and MRI and the endomyocardial biopsy. And they can be treated very well if the diagnosis is confirmed. The other important is the snake bites, which can lead to the myocarditis also in some of the patients. And we should always look for the possibility of the patient develop the clinical symptoms of LV dysfunction. Then some commonly used drugs like anti-diabetic drugs, like antibacterials like sulfonamides and tetracycline, cephalosporin can also lead to development of myocarditis if they are used for long terms. Viruses already we have discussed, and this is the journey of the various viruses have been discovered as the cause of myocarditis right from the 1950 to 2020, which they've seen evidence of SARS-CoV as a cause of myocarditis in some of the patients, and this lead to sudden death. So as far as the pathogenesis of viral myocarditis is concerned, after the initial exposure to the virus gets installed in the myocardial cells and it replicate in the nuclei, which leads to development of acquired immune response. And later on, either there may be full recovery or there may be persistent viremia or bacteremia, and which can lead to development of cardiomyopathy and LV dysfunction in long terms. Bacteria are usually less common cause of myocarditis, but as I discussed, some of the cases they may lead to the development of the myocarditis, especially in the form of if there is septicemia and there is systemic the, the distribution of the bacteria may lead to the endocarditis or myocarditis both. And in young children, post diphtheria is one of the important cause, and we should always try to look. Because most of these patients will usually go to the ENT surgeon, but the patient may present with complete heart block or may have sudden death also. Rheumatic heart disease, post-streptococcal infection can lead to development of myocarditis, as which is seen classically in patients with acute rheumatic fever, and which can be treated with the use of penicillin and other drugs. Physical agents like chemical toxins, environmental factors can also lead to development of myocarditis. And we should be always vigilant to make the correct diagnosis, so that if we take care of the inciting agent and we remove the inciting agent, there are chances that the process may reverse and there will be complete recovery. So as far as the clinical syndromes are concerned, it has wide ranging potential presentation. There may be bimodal distribution depending on the population we are studying. The clinical picture may be either asymptomatic electro ECG abnormalities. So if we have some ECG abnormalities like STT changes, T wave inversion, which may be just a subtle finding and which may just pass as a normal variant, But if you pay careful attention, if the patient has some atypical chest pain, then we should try to look for that if there is evidence of underlying myocarditis in the form of doing the myocardial enzymes or doing the other biomarkers. Some of the patients may have transient ECG abnormalities or echo abnormalities, which have been observed, which are frequently, especially in acute viral prodrome outbreaks. And if you do the echo examination of these patients, we may find some abnormality of the cardiac function on echocardiography. Most of the patients who have myocarditis, they have chest pain at the important cause because of the inflammation. There may be associated myocardial as well as the epicardial involvement, which leads to inflammation. And some of the patients may have associated the adjacent pleura may also get involved, and that can get to the chest pain, which may be associated with ECG abnormalities, including the ST segment elevation, because there is acute myocardial the transmural inflammation, which can lead to ST elevation also, and can sometimes confused with the coronary artery disease. And coronary vessels can be demonstrated if you do coronary angiogram. But most important differential is that if we do the angiography of these patients, the angiography is totally normal. And these patients have typical findings of the chest pain with ECG abnormality. And if we do the biomarkers, I think biomarkers will be elevated, and that will lead to the diagnosis of myocarditis rather than ischemic heart disease. Most of the time, it has a bimodal presentation, like as we discussed in early childhood, the incidence of myocarditis is more, and similarly in the older age population. But the presentation is different. As I said, in younger age population, the mortality is high compared to the older age population. It may be because of the older age population have repeated insult or repeated exposure to the viruses, which leads to the development of immunity, and therefore they have less chances of complication compared to the infants and young generation. And if the inflammation persists for long duration, it can lead to development of dilated cardiomyopathy, which may be responsible for around 10 to 15% of the new onset dilated cardiomyopathy patients in the general population. And it has been associated with development of heart failure with both systolic and diastolic function. So we should always pay attention to diastolic heart failure also, not only systolic heart failure. There are certain clinical clues which can lead to the diagnosis, and for the diagnosis of myocarditis, and especially for the etiological diagnosis, that this may be the possible etiology for the myocarditis. Like presence of B19V frequently cause chest pain and endothelial dysfunction. So most of the patient chest pain is more common. Similarly, ventricular arrhythmias and heart blocks are more common with giant cell myocarditis. So if somebody has significant ventricular arrhythmias and heart block on ECG, we should suspect giant cell myocarditis. Presence of enlarged lymph nodes, especially the hilar lymph nodes on chest X-ray, and the clinical evidence of myocarditis usually gives clue that patient may be having underlying sarcoidosis as a cause of etiology of myocarditis. And pleuritic pain of the skin, maculopapular rash, and evidence of eosinophilia can lead to the diagnosis of hypersensitivity to the drug or toxin. So if they have evidence of eosinophilia, maculopapular rash, and pleuritic rash can lead to diagnosis of hypersensitivity myocarditis. There are various studies which have shown, uh, depending on the clinical presentation, there may be different specific findings, like 25% had cardiac sarcoidosis or giant cell myocarditis compared to the general population if there is evidence of AV block on ECG. So if you have conduction block, the chances of giant cell myocarditis or sarcoidosis is higher compared to the other forms of myocarditis. And in clinical practice, distinction between non-inflammatory and inflammatory myocarditis may be difficult unless we do the endomyocardial biopsy. So biopsy still remains the gold standard as far as the diagnosis of myocarditis is concerned. Depending on the clinical presentation, it can be divided into different categories, like acute myocarditis, where the short history of viral prodrome, which is associated with the history of upper respiratory infection or flu-like illness, followed by cardiac symptoms, ECG changes, ST elevation of biomarkers, and after some time the symptoms are resolved. This is known as acute myocarditis. But in some of the patients, like 10% of the patient, the myocarditis may worsen, and within a span of 2 weeks, the patient may deteriorate significantly, which may require hemodynamic support in the form of use of vasopressor, or sometimes the mechanical support to sustain their life. This is known as fulminant myocarditis. And if you do the endomyocardial biopsy in these patients, it reveals typical diffuse myocarditis involving the whole of the myocardium of both right ventricle and left ventricle. And unless treated in time, it may be fatal and can lead to death in this patient. Giant cell myocarditis, I have already discussed. They have typical histological findings of presence of giant cell in the endomyocardial biopsy, and these patients are usually are having increased incidence of heart block and ventricular arrhythmias, evidence of heart failure. And if we make the histopathological diagnosis, immunosuppressive therapy remains the treatment of choice in these patients. If you do a repeated biopsy and patient has persistent symptoms for more than say 4 to 6 weeks, then the diagnosis of chronic active myocarditis can be considered. And 60 to 70% of the patient with active or borderline myocarditis who presents with dilated cardiomyopathy, recent onset dilated cardiomyopathy, can be because of the myocarditis. And if you do histopathological biopsy in these patients, the diagnosis can be confirmed and the appropriate management can be started in these patients. Similarly, eosinophilic myocarditis. These are the different forms of eosinophilic myocarditis, which may present as in either in form of solid tumors, and because of the increased eosinophil counts, hypersensitivity reaction to drugs, parasitic infection, or hyper eosinophilic syndrome, eosinophilic granuloma with polyangiitis. These are the various presentations in which we have systemic eosinophilia along with evidence of myocarditis, which has two forms, that is a necrotizing form where there is severe necrosis of the myocardium, or there may be a thrombotic form where there is formation of intraventricular thrombi, which may be commonly seen in the right or left ventricular apex and associated with systemic eosinophilia, which is classically seen in Loeffler endocarditis or Loeffler myocarditis. Some of the patients in peripartum period also can develop the LV dysfunction or dilated cardiomyopathy. And if we do the biopsy, some of these patients of peripartum cardiomyopathy can show evidence of myocarditis, and this can be treated. But most of the time, the biopsy is not performed in patients of peripartum cardiomyopathy, and they are just treated empirically. Usually, it is reversible, and within 6 months, the changes reverses, and the LV function is restored. There are few cases who have lymphocytic infiltrate and they have typical lymphocytic myocarditis, which can be also present in acute diffuse lymphocytic myocarditis or chronic inflammatory myocarditis, and they can be differentiated by clinical presentation, presence of chest X-ray findings, or the cardiac magnetic resonance findings, and they can be treated accordingly. So as far as the diagnosis is concerned, part of the diagnostic criteria I already discussed. The endomyocardial biopsy is the gold standard, but it is not available. Biopsy is not available. It is not feasible, and it is invasive procedure. So it is not possible in most of the patients to make the diagnosis of myocarditis. So clinical presentation with presence of raised biomarkers, especially in the form of CPKMB or muscle enzymes, troponin T with imaging findings, are the main diagnostic criteria. So depending on the clinical features, it can be divided either the possible myocarditis, probable myocarditis, or definitive myocarditis. So if we have definitive histopathological examination on endomyocardial biopsy, then diagnosis is definitive myocarditis. Otherwise, if we have elevation of biomarker ECG findings or abnormal cardiac function on echocardiogram or CMR, along with the symptoms, then it is labeled as probable acute myocarditis. And if there is absence of symptoms, then it is labeled as possible myocarditis. So laboratory findings, I already discussed, especially the cardiac enzymes in the form of CPKMB, troponin are most specific, and if troponins are raised of more than 0.06 microgram per liter, they are associated with poor prognosis and development of dilated cardiomyopathy in the future course of the disease. Anti-pro-BNP, the new biomarker, which basically gives rise to the idea about the ventricular function. If the NT-proBNP rate that shows that patient's LV function is significantly decreased, and if it is very high, then chances of mortality and acute decompensated heart failure is more, and they should be treated aggressively compared to those who have low or normal NT-proBNP. Anti-heart antibodies, especially in some of the cases like antiviral antibodies, are frequently used in recent terms, and similarly, the immunohistochemical chemical the diagnosis is also used for the diagnosis of myocarditis. ECG is most common, but it is totally non-specific. But some of the patients may have wide QRS because of the myocardial involvement, or they may have conduction disturbance because of the involvement of the His-Purkinje system, or may develop ventricular or atrial arrhythmias because of the atrial or ventricular myocardial involvement. So any ECG finding can be there, but this is not specific for the diagnosis of myocarditis. So cardiac imaging remains the most important diagnostic tool as far as the diagnosis and management is concerned, and echo is the most important, which is readily available, and it can be done in most of the patients, even in the acute condition, and when the patient is very sick, it can be done at bedside, so that the evidence of RV or LV dysfunction can be detected on echocardiography. But cardiac MRI is the other sensitive tool or the diagnostic tool. If the patient is stable and the CMR can be done, then the diagnosis of myocarditis or the probable diagnosis can be made depending on the myocardial, the fibrosis, the findings of the CMR. So this is one of the MRI scan which shows this is the normal without the contrast element, that is gadolinium minimus, and this is the showing the patchy area of inflammation which is subendocardial in the distribution, which is classically seen in patients with myocarditis, and which is not in the distribution of the coronary artery disease. So it is not because of the myocardial infarction, but it is because of inflammation. CMR, which shows evidence of increased signal to intensity ratio or presence of edema and patchy distribution, is one of the diagnostic criteria for the myocarditis. And it is very sensitive and specific. So it is almost 60 to 70% sensitive and so 40% specific in most of the patient. But if you look at the current protocols, I think 70 to 80% of the patient myocarditis can be diagnosed with the use of CMR. And the classical criteria which are applied to diagnose myocarditis are the Lake-Lewis criteria, which are described as in the regional global increase in the signal intensity of the myocardium on T2 weighted images, increase global myocardial compared to the skeletal muscle imaging, and there is at least one focal lesion of non-ischemic regions of focal evidence of myocarditis in the form of edema or high intensity signals. So if any criteria is present or criteria 3 is present, the diagnosis of myocarditis can be made. And a repeat CMR study can be done after 1 to 2 weeks, and which can confirm the diagnosis. The only nuclear study which is used is the FDG PET, which is done in most of the patients to make the diagnosis of cardiac sarcoidosis, because it can it can show that the lesions are active and they need immunosuppressive therapy. Otherwise, the role of the nuclear imaging limited in the diagnosis of myocarditis. Biopsy is the gold standard, and we have already discussed. And but it is not available, and it is slightly risky, and it is a procedure. But in patients who have acute onset the cardiomyopathy or acute onset heart failure, the patient is requiring inotropes. He has intermittent heart block. Patient has recurrent VT or is not improving with the guideline directed medical therapy within 1 to 2 weeks, then the cardiac biopsy is indicated, and these patients should be treated according to the biopsy finding. So biopsy is warranted in these patients, and then they are accordingly treated. So the uh, guideline directed therapy, if it fails, then biopsy is warranted in these patients. And most of the patients with giant cell cardiomyopathy, usually less than 6 month duration, they recover the findings. But if the inflammation or the persist for more than 6 months, then they lead to the chronic myocarditis and development of dilated cardiomyopathy. Similarly, presence of eosinophilic granulomatosis or the sarcoidosis can be detected based on the endomyocardial biopsy, and they can be treated accordingly. As far as the prognosis is concerned, as I said, most of the times the acute viral myocarditis is self-limiting disease. Within 2 to 4 weeks or up to maximum 6 weeks, the most of the patients recovers. Only 5 to 10% may have persistent symptoms or signs, and they may have evidence of valve dysfunction. And some of the patients, as I said, may have acute fulminant myocarditis, which can ultimately lead to death. But most of the time, it is self-limiting disease, and that is fortunate that most of the times myocarditis it is self-limiting, and if the patient develop valve dysfunction, then guideline directed therapy is warranted these patients. If the patient develops significant valve dysfunction or recurrent ventricular arrhythmias, then they should be treated with assist devices to improve the ventricular function to give the rest to the myocardium, and later on the assisted devices can be removed, or patient can be listed for the transplant if the patient is not the LV function is not recovering. So, in the last part is the treatment. There is no definitive treatment, but as I said, like some of the patients, they have a specific etiology as far as the myocarditis is concerned. Like in giant cell myocarditis or sarcoidosis, they can be treated with immunosuppressive therapy or steroids. But if the patient has evidence of dilated cardiomyopathy and syndrome of acute heart failure, then they are treated as the guidelines of ADACC-AHA guidelines for heart failure, which include the ACE inhibitors if they're not contraindicated, beta blockers in the form of SGLT2 inhibitors, and the aldosterone antagonists. So all patients should receive, apart from use of vasopressor if their blood pressure is low. And if they have evidence of significant viremia or inflammation, then some of the patient interferon beta is also used in the patient, and use of steroid and immunosuppressive therapy in the form of azathioprine or intravenous immunoglobulin has been tried in some of the patients, especially in giant cell cardiomyopathy or sarcoidosis. If the patient deteriorates, ventricular support device is used in the form of either Impella or ventricular assist devices. These are known as left ventricular support devices, which can be used for some time, or the extracorporeal membrane oxygenation, like ECMO, can also be used if the oxygenation is not properly maintained. And survival rates are improved in this patient if the patient undergo transplant for the acute decompensated heart failure. So this is the algorithm which shows how the patient's acute myocarditis should be maintained. If the patient is a stabilized hemodynamic, use of diuretic and vasodilators and ACE inhibitors, ARB, beta blocker, these are the guideline therapy should be given in this patient. If the patient remains stable, we should follow up and repeat echo and CMR and then continue the treatment. If the patient's ejection fraction is less than 35%, then implantable ICD should be considered to decrease the risk of sudden death because of the ventricular arrhythmia. But if the patient is not hemodynamic stable or patient deteriorates, then we should try immunotherapy in the form of azathioprine, steroid, or interferon. And they have inotropic support, balloon pump, or left ventricular support devices. Finally, they can be subjected to cardiac transplant if the patient is not recovering, even after mechanical support devices. These are the various online the algorithms that are available as far as the acute management is concerned. Similarly, the role of biopsy. So what is the future? One of the major gaps in the management of myocarditis is the lack of diagnosis and specific non-invasive tests, because the diagnostic criteria at the end of myocardial biopsy, which cannot be performed in every patient. And the diagnostic techniques are evolving to identify the novel blood-based biomarkers, which can make the precise diagnosis of myocarditis, which includes microarray and proteomic analysis of the tissues which are obtained from the laboratory models. With improved understanding of the pathophysiology mechanism, new therapies are developed, especially cell-based therapies like selective inhibition of the T cell responses or induction of apoptosis of T cells and increase in TREG cells, which may be the future management as far as the treatment of myocarditis is concerned, especially in subset like giant cell myocarditis or lymphocytic myocarditis. And translational studies focus on genomic markers in biopsy samples, and peripheral blood should all refine assessment and target therapies to population of the highest need. So it is an evolving field, and it is an interesting field. And some of the patients, some patients may be life-threatening if we make proper diagnosis in time and advocate proper therapy in time. Thank you very much for the patient listening. And if you have any questions or any comments, I think everybody is most welcome.
Hello.
Hello.
Yeah, sir. There are also some questions now.
Yeah.
So I will be posting one by one question in the chat section.
So I'll see this chat. I'll see.
I will be posting those questions. I have not posted yet.
Okay. So I then you can take one or two questions because I have another meeting just lined up. So I'll be leaving in short time, within 2 minutes, I think. So if you can have one or two questions, then I think we can wind up. Thank you. Yeah.
The first question I have posted.
Could we detect viruses from systemic blood of the patients having myocarditis if there is no endomyocardial biopsy? So that's what I have said recently. There are new techniques which are being developed, but presence of viremia in the blood does not prove or support that patient may be having myocarditis. So presence of virus in the endomyocardial biopsy tissue is the diagnostic tool that it is 100% diagnostic that patient has myocarditis. Virus may be present in the blood sample, but that doesn't mean that patient may be having an underlying myocarditis also.
The second question also I have posted.
So we have seen how to use the safe drugs and what are them in the challenging situation of comorbidities. And so there I have shown some of the drugs which are usually the agent cause. So these drugs should be avoided in these patients. And if we think that patient had developed the evidence of clinical features or the imaging, especially on the echo, after starting of some drug, I think we should have a temporal correlation that the early dysfunction or myocarditis second to the drug. So this should be offended, and these drugs should be avoided. Otherwise, most of the drugs which are like guideline-directed therapy, they can be safely used in these patients. And if the patient has arrhythmia, beta blockers, like if they have underlying conduction disturbance, beta blockers should be avoided. And if the patient has ventricular arrhythmia, the antiarrhythmic drug, depending on the type of arrhythmia, can be used in these patients.
Sir, the last question.
Yeah.
I've uploaded the question, sir.
Why immune checkpoint inhibitors cause myocarditis? It is all inflammatory. The immune checkpoints, whatever the drugs we are using, whether the inhibitors or anybody can have inflammatory response. It is a foreign agent which can lead to the generation of the antibodies, and that can lead to development of myocarditis. But how far is what is the role as far as it is still controversial, and we're not sure because we don't have large clinical trial data or large data to support the hypothesis. But I think we should be cautious and we should be highly vigilant so that we can make the diagnosis and we can take out the inciting agent so that the further deterioration of the myocarditis process can be halted and it can be reversed or it can be treated in time.
Yes, sir. Thank you very much, sir, for your valuable time and sharing important insights on the topic, sir.
Yeah, thank you very much. It is interesting. I think it is neglected, and that's why it was important that you chose this topic. So
Yes,
thank
sir.
you, IGCP, and thanks everybody for listening.
Yes, sir. Yes.
Okay.